Hi, my name is Paul Sylvester, student representative to the Greater New York Regional Chapter at ACSM. Our next speaker is Jeff Young. Jeff Young, kinesiologist, works primarily in medical fitness and has worked at world-class facilities such as Duke University, UCLA, and Beth Israel Medical Centers, and as the founding fitness coordinator and faculty practice provider at Mount Sinai Medical Center's Center for Health and Healing in New York City. Currently, Jeff operates his own company in New York City, which implements and oversees medical fitness and post-rehabilitation patient services at a clinical facility in Manhattan. He serves as an expert peer reviewer for the NSCA's Strength and Conditioning Journal, a subject matter expert for the American Osteopathic College of Physical Medicine and Rehabilitation, a dual committee member for the American College of Sports Medicine's Greater New York Regional Chapter, and the continuing education provider for the National Academy of Sports Medicine. Additionally, Jeff is the founding chair of a fitness and medicine group within the American College of Lifestyle Medicine, an internship provider for exercise science and kinesiology students at several colleges and universities, and the board member for Penn State University's Kinesiology Alumni Program. And now, we're happy to present Jeff Young.
Hey everyone, I'm Jeff Young, a kinesiologist, certified strength and conditioning specialist, and I'm also ACSM Exercises Medicine credentialed. I'm in my 25th year as a professional, and pretty much anything related to medical fitness is my area of expertise. I'm definitely excited to bring you this presentation, partly because it piggybacks off of Thomas Hammett's great presentation from his clinician's perspective, and partly because I'll be able to give you information on how to build a relationship with clinicians that you probably weren't aware of. So I hope you enjoy it. Please don't hesitate to reach out if you have any questions. So I'll begin with the ever-exciting disclosure that I have no conflict of interest in relation to this presentation. The primary objectives for this presentation are to explain why physical therapists and other healthcare providers should collaborate with exercise specialists and vice versa. To explain the benefits of including a fitness component within a medical clinic. To give some tips on how exercise specialists can increase the chance that local clinicians will refer patients to them. To explain how to overcome perceived barriers. And to give a real-life example on how I went about establishing a successful business within an independent physical therapy facility and created additional revenue along the way. As Thomas mentioned in his presentation, the physical therapist to exercise specialist connection is an intuitive connection. To move directly from acute rehab into post-rehab and general fitness or performance enhancement makes so much sense that it should be common sense. Having said that, the clinician to exercise specialist bridge spans across many medical disciplines, including chiropractors, registered dietitians, nurses, physician assistants, physiatrists, and many more. So while this presentation will emphasize the physical therapist to exercise specialist collaboration, the general concepts will apply across many disciplines. Let's start off with why an exercise specialist should collaborate with a physical therapist and vice versa. Many people in sports medicine don't understand strength and conditioning guidelines, and many people in fitness and strength and conditioning don't understand sports medicine guidelines, but the two go hand in hand. This underscores the need for us to learn from each other. I'll begin with exercise specialists and list some of the many things that we can and should learn from physical therapists, which will help us become better professionals. First is to better understand the phases of musculoskeletal rehabilitation. Generally speaking, there are 4 phases: reducing pain and inflammation, restoring joint range of motion, improving motor control and general strength, and then progressing the program from there. Since the number of sessions for each patient is dictated by insurance, many times PTs aren't able to move to stage 4. And even if they are, they often aren't able to spend optimal time in this stage, which underscores the need to transition patients to an exercise specialist. But it also underscores the need for us to understand the flow and progression of these stages with each patient referral. Even though we aren't licensed or skilled in many of the modalities that rehab professionals use, and may not use specific rehab philosophies or approaches, it's still empowering to learn the language of sports medicine and therapeutic exercise to better understand how to approach joint pain and various musculoskeletal conditions. While it's outside the scope of this presentation to go into detail about this, one of the most important things I've learned through working alongside physical therapists and physiatrists is that there are 6 components of a healthy musculoskeletal system. Neuromuscular control, which is synonymous with proper form, strength, strength endurance, joint stability, posture and alignment, and mobility, which has 3 subcomponents: flexibility, myofascial mobility, and capsular mobility, such as your ankle, hip, and shoulder capsules. This information has helped me understand the corrective for pretty much any type of joint pain or musculoskeletal issue that no longer needs acute care, because it's taught me to see program design and correcting imbalances and dysfunctions through the eyes of each of these components. For example, by learning this concept, I was eventually able to understand the importance of designing programs to create flexibility and strength balance around each major joint, and more specifically, how to do these things. And I learned how each of these components apply no matter what the musculoskeletal condition is, no matter where it is. It's information like this that's invaluable, which we just don't learn otherwise. The list of injuries and conditions is very long, and many of them have types or stages. 2 examples would be the stages of disc herniation and the stages of osteoarthritis. Knowing this type of information can greatly help designing safe and effective programs for patients, which, once again, we typically don't learn otherwise. Examples of contraindication might be knowing to avoid excessive spine extension if the client has been diagnosed with spinal stenosis, or being sensitive to squat depth for various knee issues. More specifically, if someone suffers from grade 1 or 2 knee osteoarthritis, they may likely be able to squat to parallel or even slightly below parallel, whereas parallel squats would likely be contraindicated for a person with stage 3 or 4 knee osteoarthritis, especially squats under moderate to heavy loads. Examples of indicated exercises might be Pilates mat exercises for clients with a deconditioned core who are experiencing low back pain, such as this modified prone bird dog exercise, or dying bug exercise, or bridges or hip thrusts for clients who are suffering from patellofemoral syndrome. Two examples here might be thinking that the gym rat method of an upright row is okay, only to learn that this exercise needs to be modified like this to be safe for most people. Or realizing that machine knee extensions are only questionable if they aren't being performed within the individual's pain-free range of motion, and that by determining pain-free range of motion first, starting with appropriate loads and progressing in small tolerable increments, this supposed questionable exercise can become an important therapeutic exercise to insert into the program. Proper cueing is something seasoned PTs are very good at, and something that many exercise specialists feel uncomfortable with. This is another area I learned a lot from through working alongside physical therapists, which increased my confidence and greatly helped with correcting improper form and helping to establish mind-muscle connections with my clients. By working with and learning from PTs, I became much more skilled at what specific words or phrases to use, better understood when and how to professionally touch a client to help them focus on the muscles that are supposed to be working in a given exercise, and also understood how to explain to clients exactly where they should be looking in the mirror and what to look for visual feedback, or what to point out to them if I recorded their set with a cell phone. Most exercise specialists don't remember or assess joint range of motion on clients. This was exposed to me as well, and once I learned them and began assessing joint range of motion, I really improved at noticing and correcting movement compensations and was able to correctly design flexibility training programs for my clients. More specifically, they brought to my attention that stretching clients where they subjectively feel tight, or stretching areas because it's the common thing to do, isn't how to balance flexibility around joints, which should really be the purpose of a flexibility program. Instead, we should be taking the time to assess each major joint in the body so we can know exactly where our client is tight, normal, or hypermobile. And then we have the correct information to place them on a proper program. When one exercise is contraindicated or causing discomfort, it's always great to have a large toolbox of exercises to fall back on. While resistance training programs should revolve around primary exercises whenever possible, learning from rehab clinicians can increase a trainer's knowledge of different variations of primary exercises, which ones are the most appropriate to use in certain situations, or when to insert appropriate assistance exercises into a program to strengthen a weak area. One thing I never knew prior to working alongside sports medicine professionals is that for each major joint in the body, there are standard exercises which tend to be safe in most situations or under most conditions for the affected joint. Now that I know my joint-friendly exercises, I can confidently design programs for just about any musculoskeletal condition. Two quick examples. For the shoulder, there's a concept known as the shoulder safe zone. This concept is pretty well known in sports medicine, but rarely known in the field of strength and conditioning. Simply put, it basically means that the upper arm generally wants to be near the torso when there's shoulder pain, and also prefers not to have to press or reach overhead. So the trainer should begin with exercises like rows, reverse fly variations, and scaptions, and then eventually progress to landmine press variations, and possibly overhead press if possible. Another example is that deadlift variations and bridges or hip thrusts tend to be knee-friendly in most situations, as long as the initial load and rate of progression are appropriate. This is because these exercises are hip-dominant instead of knee-dominant and emphasize the posterior chain, which strengthens the muscles that help stabilize and decompress the knee. I may not have known these things if it hadn't been for collaborating with sports medicine professionals. And then 3 more examples which are also pretty self-explanatory. Learning various progressions and regressions, increasing understanding of pain science and when it's okay to exercise with some pain, or how to safely and confidently work around pain, and understanding when and in what situations a client should be referred back to a PT. On the other side of the coin, there's a list of reasons why a physical therapist should collaborate with an exercise specialist. One is to better understand the transition from rehab to strength and conditioning. I say this because many PTs don't have a background in exercise science and strength and conditioning, and learn early on to default to home exercise programs when a patient is being discharged. In situations like this, we can explain the concepts of periodization, the importance of revolving programs around primary exercises when possible, and the importance of continued progression, among many other things. Closely related to the above point is, once again, the fact that many PTs automatically default to placing patients on low volume, low intensity, low variety home exercise programs upon discharge from therapy. By its very nature, The physical therapist to exercise specialist collaboration will increase the awareness of the inferiority of these types of programs. We need to move post-rehab far, far away from the standard 2 to 3 sets of 10 of a handful of exercises. There are many physical therapists who are hesitant about incorporating exercises like squats, especially squats where the thighs go below parallel, deadlifts, and bent over barbell rows. Into a patient's program. But unfortunately, some old myths die hard. There are still a subset of not just PTs, but doctors and other healthcare professionals who are of the belief that these types of exercises are bad for your joints. We can play a role in educating those who have these fears because ultimately the patient wins when we're all on the same page. And while there are many more reasons why a physical therapist should collaborate with an exercise specialist, the last on my list for this presentation is to increase the awareness of using physical therapy as a launching pad to move the patient from rehab straight into the fitness and wellness domain. In other words, the paradigm needs to change. When a patient is discharged, their exercise should no longer be exclusively based on where they were injured or in pain. Instead, they should automatically be placed on a progressive, total body, periodized strength and conditioning program where the design of the program includes the special considerations for their areas of pain or dysfunction. Referring back to phase 4 of the stages of musculoskeletal rehab, much of what is listed here doesn't occur in rehab, especially for general and special populations, and yet for the patient to truly benefit and to optimize their health and fitness, this is the phase they should be moving to as a lifelong form of exercise. To decrease or negate joint pain, decrease the risk of re-injury, and for overall wellness, it's critical that an exercise program includes an increase in variety of exercise, strengthening across multiple repetition ranges, primarily the 6 to 15 range, and includes force absorption exercises like step downs and hops. Stage 4 is one of the biggest missing links in rehab and is a primary reason why this collaboration needs to occur. Moving on to the benefits of including a fitness component within a medical clinic. It increases revenue for the facility with negligible overhead, or in other words, it's free money. It enhances the brand of the clinic and makes them more marketable to doctors and the public. By adding a fitness component, any type of clinic, whether rehab, diabetes, or hospital as examples, will immediately better mimic a comprehensive wellness facility. Doctors will be more likely to want to refer patients, and many people who wouldn't work out otherwise at a typical gym or health club would be more likely to want to work out in this type of atmosphere. This is something that so many exercise science and kinesiology students and recent alumni don't even realize is an option for them as a job and career opportunity. Medical clinics which don't currently include a fitness component are medical fitness facilities waiting to happen. With tens of thousands across the United States, if it was normal for clinicians and exercise specialists to work together, many job opportunities would be created. Think about what this would mean on a large scale. If it were commonplace for the thousands upon thousands of medical clinics to include a fitness component, and if clinicians were referring patients as a normal part of their practice, we'd have a much larger fraction of the population not only exercising, but engaging in structured, progressive exercise guided by qualified professionals. This would make a huge dent in the obesity epidemic, especially if you added into this picture regular collaboration with registered dietitians. Since I've worked in these types of atmospheres at Duke University, Beth Israel, and Mount Sinai medical centers, it's mind-boggling to me that this isn't the norm. Patients love knowing that they are working out in an environment where the trainings occur under the watchful eye of clinicians and where their trainer has direct access to their healthcare provider. This type of situation also forces trainers to bring their A game every session, unlike what occurs in most big box health clubs where there's little to no oversight into program design, little to no emphasis on continuing education, and where the primary concern of the management is whether or not the trainers are hitting their revenue numbers every month. And now moving on to potential barriers to collaboration and how to overcome them. A primary reason for the disconnect between medicine and fitness is a lack of trust. Since there's no regulation in the fitness industry, which allows for the field to be filled with fads, gimmicks, myths, lack of standards, and many uneducated trainers, clinicians are justified to be slow to trust trainers and coaches. Ways that we can overcome this barrier include offer a free consultation and assessment, and some free training sessions to your referral sources so they can experience firsthand what you do. Perform in-services, which is another name for professional development meetings or workshops, as a way to both educate clinicians on a topic they may not be familiar with and to show them examples of your knowledge and skill level. Regularly communicate with clinicians by asking them for their input on the design of a program whenever a patient is referred. And give occasional feedback by providing data on how their patients are improving and progressing by being on your programs. This is another part of the disconnect between medicine and fitness. Clinicians are all about data collection to know objectively that a method is beneficial to their patient. Many trainers are in the habit of not keeping training logs, don't perform initial and ongoing assessments, and don't track health biomarkers such as blood pressure, blood sugar, and cholesterol. Fitness professionals need to understand that to effectively work with clinicians and gain their trust, we need to collect and track data and give the referral source occasional feedback so that we're all speaking the same language. Patients can also have a lack of trust for trainers for the same reasons that clinicians do. They suffer from one or more conditions and may be afraid that the trainer will work them too hard or lacks the knowledge to design a safe program. The primary way to overcome this is for the clinician to allow the exercise specialist to help implement therapeutic exercise during the rehab process, or at the very least, to introduce the patient directly to the trainer and boast on the trainer's behalf about their knowledge and skills. Or in other words, highly recommend the trainer. I collaborate with the chair-elect of the board of directors for the Medical Fitness Association, Jeff Duran, and have to give him credit for the attention getters information. He has a ton of experience with this and provided me with this information for a subcommittee he and I chair for the American College of Lifestyle Medicine called a Patient Referral Subcommittee. These next few slides will be about getting the attention of clinics so they will refer patients to you where you train the patient elsewhere, such as a local gym or health club. Later in the presentation, I'll give some tips on setting up shop within a clinical facility using an experience I had with a physical therapy facility as an example. In the situation where a trainer is going to make a call to the clinic, they can ask for the office manager and say something like, "Hello, my name is so-and-so. I'm an exercise specialist in your area," and of course you can add whatever other credentials you want to give. "I wanted to stop by and see if I could drop off some complimentary coupons and let your employees know about some of the exciting programs I could offer your team and your patients. Could I stop by for 15 minutes of your time to discuss these offers?" Obviously, this is a general template, and you would need to adjust the wording based on your situation. For an unannounced office visit, you could say something like, "Hello, my name is so-and-so. I'm an exercise specialist in our area. May I speak to your office manager?" And then to the office manager say, "I wanted to stop by and see if I could drop off some complimentary coupons for your staff and let them know about some of the exciting programs I can offer them and your patients." A key point here since this is an unannounced visit, is that you would wait in the office for as long as it takes to see someone. Don't take no for an answer. The coupon should include complimentary sessions for staff members and then discounted starter packs for their patients. Two more examples of things you can say would be, I can help your clinic provide better patient care at no cost to you. Do you have 10 to 15 minutes for a conversation to learn more? And I can help you manage your patient's overall health by providing a comprehensive medical fitness program at no cost to you. Are you interested in learning more? Also, it's very important to continue the relationship with these clinics. Stop by often with promotional items and coupons. Next on the list is how to overcome perceived barriers with patients. Many people, patients, and even clinicians have an all or nothing mindset. Because of that, they create barriers in their mind without considering the list of options. This is where we come in to try to break down those barriers. For every supposed barrier that exists, there are ways to get around them. On the subject of perceived lack of time, we can suggest that the patient find some time on one or both weekend days and train with an exercise specialist once per week. Another option is for the exercise specialist to offer 30-minute sessions, or create a platform where the first several sessions are held virtually at the convenience of the client, saving them the time to have to travel to a facility. Use those virtual sessions to show your value, and then suggest to the client that they come in for some in-person trainings. Another option is to create a situation where they only need to come in once or twice per month. The other sessions are performed virtually or by sending them a simple program through email. And then again, use the in-person sessions to show your value and suggest that they increase to 3 or 4 sessions per month or more than that if possible. This is probably the biggest barrier since insurance doesn't cover fitness training sessions. Having said that, most of the large insurance companies do offer reimbursements. The way it typically works is that the client has to show the insurance company they've performed X amount of sessions over a given time period, such as 20 sessions in 3 months. And then the insurance company will reimburse a couple $100s. This is a situation that most people don't know about, and it may sway their decision. Other options to consider include complimentary sessions within a package, such as buy 5, get 1 free, occasional discounts, such as I'm offering a discounted 5-pack this month, partner or small group training as a way to share the cost, or 30-minute sessions and or virtual sessions as a way to reduce the cost. This perceived barrier is also high up on the list, and while we, the fitness professionals, can provide motivation by setting up the sessions so that the client regularly experiences success, point out to them their improvements and progressions, and provide support both during the sessions and in between sessions, in a clinician fit pro relationship, it's actually part of the clinician's role to provide motivation by guiding patients through the stages of change and highly suggesting structured, guided exercise to their patients, along with talking up the fit pro as though it's a no-brainer that they at least take advantage of the initial consultation and assessment. Before I wrap this up, I want to take you through one of my experiences which will hopefully provide more insight on how to create a successful model. Back in 2010, my wife and I moved to Los Angeles. We thought it was going to be a permanent move, but we weren't fans of LA, so fortunately it only lasted for a year, and then we moved back to New York City. Prior to moving out there, I hopped on Indeed.com and Craigslist and found a few physical therapy facilities that were looking to bring on a fitness trainer, so I contacted each of them and set up interviews when we arrived in LA. The facility I ended up working at was called Westwood Physical Therapy, and the reason I chose it is because they were a blank slate. At the time, they didn't have a fitness component or preconceived philosophy, which allowed me to set up my business exactly how I wanted. This is tip number 1. It would be optimal to find a facility that's a blank slate. I was also able to tell by speaking with them that they understood the need to refer patients following discharge. It's critical to find clinicians who get it and who want to refer instead of always defaulting to home exercise programs. Referrals need to be built into the system, otherwise, the medical fitness component isn't going to be successful. During the interview process, I sold myself by explaining that I'm a kinesiologist with experience working with special populations, that I always design programs along with input from the referral source, and that I revolve my philosophy around the ACSM's guideline to start low and progress slow, or in other words, meet the patient where they're at and progress in small, tolerable increments. I knew going into it I was going to have to spend time there without getting paid to establish my presence and gain the trust of the providers. I used that time to offer free consultations and free training sessions for the entire staff. 2 of the physical therapists decided to continue to train with me, and I offered my sessions for them at half price because I knew the payback would be in the form of patient referrals. It also allowed me the opportunity to get to know them better, further gain their trust, learn from them, and teach them things about strength and conditioning that they either didn't know or weren't comfortable with. This was probably the most important part of my success at that facility. I set up my fee schedule so that it was in line with the going rate for independent trainers in Los Angeles, but I also set it up so that the initial consultation and assessment wasn't much more than what patients would pay as a copay for physical therapy. It's critical to get them in the door, and the price of a copay is a language that patients speak. The owner helped me with marketing in the sense that she allowed me to place my business cards and brochures at the front desk and in each treatment area. She also had me create a PowerPoint presentation and would play it on one of the TV screens so that the patients would see the services I offered while they were warming up on a bike, treadmill, or elliptical. The PT set it up so that when the patients had about 4 or 5 visits left, they would introduce me to the patient and allow me to assist with the therapeutic exercise. Many times they'd purposely walk away and go into the office for several minutes, which allowed me one-on-one time with the patient. This was extremely important because it gave me an opportunity to use my own social skills, gain the trust of the patient, and let them know about the services I offered. It's also extremely important because it was the PT's way of letting the patient know that they had complete trust in me. From the PT standpoint, it's also critical for them to begin the discussion with some point of reference as to why they should continue with structured, guided exercise after they've finished with physical therapy. They can use the individual's pain as the reference point and explain to them that to decrease the risk of future injury or joint pain, it's important to continue to progress and increase tissue strength. Or they can use health biomarkers for patients who have obesity, hypertension, diabetes, or pretty much whatever condition they have. The point is, it's important for the clinician to begin the discussion with each patient and use their rehab and or any other conditions as reference points to move them into the fitness and wellness space. This is what I meant when I previously mentioned the need for a built-in referral system to create a successful model. The clinician has to want to do these things to transition the patient to the trainer. On the subject of additional revenue opportunities that trainers aren't aware of, while I was at Westwood Physical Therapy, I also became a continuing education provider for the National Academy of Sports Medicine and used the facility to offer CEU seminars and workshops to local trainers. Westwood PT benefited by getting exposure and the small rental fee I paid them to use their facility over the weekend during off hours. And I benefited because it was an additional source of revenue. I've now been a CEU provider for NASM for about a decade. And just to give you an idea of what type of revenue you can generate, I offer 3-hour courses where each course starts with about a 60-minute PowerPoint presentation and then finishes with 2 hours of hands-on instruction on various topics related to medical fitness. The going rate for an in-person seminar and workshop is about $20 to $25 per person per hour. So if we look at the low end, a 3-hour course means $60 per attendee, which means I make $600 for every 10 trainers who show up. If you're interested in learning how to become a CEU provider, send me an email and I have no problem explaining. I also took the initiative to set up monthly journal club meetings. Journal club is something that's common in healthcare, and unfortunately rarely exists in the fitness world. It's basically an informal discussion on the hot topic of the month, and it's based around a study from a journal article, which is why it's called Journal Club. For example, in physical therapy, they'll typically take an article from a PT journal. One month it could be on herniated discs or low back pain, the next month on rehab for rotator cuff injuries, and the next on patellofemoral syndrome, and so on. Someone will review the article and then open it up for discussion. From there, everyone will talk about their experiences, approaches, and philosophies to either learn from each other or at the very least to compare and contrast. I set up this exact same format but use strength and conditioning journals instead, such as the NSCA's Journal of Strength and Conditioning Research and Strength and Conditioning Journal. The staff loved learning more about exercise science, and I was able to bring in the local trainers as well, who loved the interdisciplinary discussion. This is also just a great way to increase the trust that the clinicians have in you, which ultimately is going to lead to more patient referrals. Lastly, because of everything I just explained, I started receiving referrals quickly, and it didn't take long before my schedule was filled up. As soon as that happened, I put up ads on Indeed.com to look for another trainer. I titled myself the fitness director, hired a trainer, oversaw their training sessions from a quality control standpoint, and had the PTs begin referring patients to the trainer. I paid the trainer a percentage of the fee and took a cut for myself. So every time they performed a training session, I made some extra money. For example, if I'm charging $100 per session, pay the facility $25 per session in rent, and pay the trainer $50 per session, I get to keep $25 for myself. I make $250 for every 10 sessions one of my trainers performs. This is also a situation many trainers aren't aware exists, but now you do. And before I completely wrap this up, let me also mention that while I've spent the majority of this presentation talking about collaborating with physical therapists as a way to get my points across, I've also worked as a fitness educator for Beth Israel Medical Center's Friedman Diabetes Institute here in New York City and UCLA Medical Center's Gonda Diabetes Institute in Los Angeles. While working at these facilities, I learned that despite the American Diabetes Association stating in a position statement that the diabetes team should include endocrinologists, nurses, registered dietitians, social workers, and exercise specialists, most diabetes facilities across the United States don't include a fitness component at all. So again, these are opportunities that most people in the fitness world aren't aware of. I was very fortunate that I was able to work on site and alongside those clinicians, which was an amazing experience. I'd recommend finding a diabetes facility, or 2 or 3 in your area. First by looking them up online to see if on their website they show that they include a fitness component. And if they don't, stop by and ask to speak with the manager or head nurse. Introduce yourself and let them know that you're aware of the importance of exercise in the management and control of diabetes, and you were wondering if you could collaborate with them. You could start by asking if it would be possible to shadow one or more of their nutritionists. This would be a perfect way to learn more about nutrition, offer them some free sessions, and then work out a situation where they begin referring patients to you. Because the truth is, you can establish a relationship with clinicians at a diabetes facility, whether you train the patients on site or out of a gym or health club that you work at. You can use the same approach at wellness centers in your area. And something else that should be connected, which is instead disconnected in healthcare, is regular collaboration between registered dietitians and exercise specialists. I've worked with many registered dietitians over the course of my career. In some cases, it was on-site at hospital facilities, but in other cases, it was in non-clinical settings. In fact, one of the first registered dietitians I worked with was out of a health club in Midtown Manhattan. We referred clients to each other, and we also learned from each other. It was a great experience. So think about seeking out RDs in your area. Connect with them and start off by asking if you can shadow them because you'd love to learn more about nutrition and about their field. And then use that as an opportunity to offer them some complimentary sessions and go from there. So in conclusion, the paradigm needs to change. The connection between clinicians and exercise specialists needs to become common sense. Of the two fields, medicine and fitness, it's more on the exercise specialist to become proactive and reach out to clinicians to bridge the gap. But clinicians should also be proactive in finding and vetting trainers in their local area to refer patients to. Bridging this gap is truly a win-win-win for everyone, and most importantly, the patient and the health of this unfortunately sick, over-medicated, overweight, deconditioned country. I hope this presentation provided you with some golden nuggets that you can use, and you're always welcome to contact me if you'd like to discuss anything. I'd love to hold a virtual meeting and keep the conversation going. So thanks a lot for watching.